Hello, guys. So, today we are going to discuss dysphagia. Dysphagia is the complaint in which the patient has difficulty in swallowing. It's basically difficulty in swallowing. It can be of two types: oropharyngeal dysphagia and esophageal dysphagia. Oropharyngeal dysphagia is actually due to neuromuscular dysfunction, and it is usually due to stroke. And esophageal dysphagia has many different causes, which we are going to explain later. When the patient comes to you with the complaint of dysphagia, there are a number of diagnoses that come to your mind. How we are going to make the diagnosis? We have to follow the diagnostic model, starting with our probable diagnosis. In probable diagnosis, there are some of the common diagnoses that come to a mind of a physician. That can be functional dysphagia, tablet induced. What is functional dysphagia? Functional dysphagia is actually the term which is used when there is no structural evidence of disease present. Tablet induced irritation, pharyngeal tonsillitis, gastroesophageal reflux disease, and reflux esophagitis. So there are some serious disorders which should not be missed, and we have to keep these serious disorders in our mind by looking at a red flags. In serious disorders can be neoplasia like cancer of pharynx, stomach, esophagus, and there can be any extrinsic tumor that is compressing the esophagus, which is leading to dysphagia. In AIDS, there can be opportunistic esophageal infections, candidiasis, and herpes simplex virus, which can make it for you to swallow, which can cause dysphagia, along with odynophagia, which is pain on swallowing. Stricture, benign peptic stricture due to chronic reflux disease, and stricture can also present in scleroderma, esophageal food bolus obstruction, scleroderma. Neurological causes can be pseudobulbar palsy, multiple sclerosis, myasthenia gravis, motor neuron disease, amyotrophic sclerosis, Parkinson's disease. Now we have the pitfalls. Pitfalls are the disorders that often get missed easily. They do not come to our mind normally. First of all, we have foreign bodies, then drugs. Patient is on certain drugs like phenothiazines, bisphosphonates, and some other drugs. Subacute thyroiditis, extrinsic lesions like lymph nodes, goiter, esophageal web, upper plummer Vinson syndrome, diffuse esophageal spasm, eosinophilic esophagitis, a cancer patient who is on radiotherapy, eclasia. Coming towards seven masquerades and seven masquerades, we have depression, drugs, and thyroid that can be the causes of dysphagia. So, what are the causes of dysphagia? Causes of dysphagia can be functional, in which there is muscle tension. The dysphagia is usually due to muscle tension. The patient has a sensation of difficulty in swallowing, but actually there is hypersensitivity of patient, or disordered pain sensation of a patient. Perception, pain perception is not is hypersensitive in these patients. Then we have neurological like stroke and myasthenia. Then we have mechanical causes. In mechanical causes, we have luminal causes like foreign body, mural like structural stricture or tumor, extramural like extrinsic tumor, that is extrinsic mass that is compressing the um esophagus like goiter. We have some of the red flags which are very important for your AMC MCQs. And what red flags we should see in a patient with dysphagia? If the patient has an age more than 50 years of age, patient has a recent or sudden onset of dysphagia, it is associated with unexplained weight loss, the patient is also having pain on swallowing, and the dysphagia is progressive. For example, the patient was complaining of dysphagia to be for solids, then later on it also became for liquids. It is termed as progressive dysphagia. Dysphagia for solids uh, signifies some serious problem, some serious structural problem, which is leading to dysphagia. Hiccups and hoarseness is present, and there are neurological signs and symptoms. These are the red flags which we have to keep in our mind, and we have to ask every patient for these red flags, and we have to see these red flags in every patient to rule out any serious disorder. Some important points, like what are the what in investigation, when investigating the patient, there are some important points like primary investigation in suspected oropharyngeal dysphagia. If the patient has oropharyngeal dysphagia, the primary investigation is barium swallow. And if you are suspecting esophageal dysphagia, the first investigation is to be of endoscopy. Barium swallow should precede endoscopy when there is suspected esophageal ring and suspected dysmotility. Now, coming towards individual causes of dysphagia, starting with benign peptic stricture. Benign peptic stricture can be caused by chronic reflux, esophagitis, pill injury. I will explain it later. Older people, they are taking time to swallow the medicine, like iron tablets are difficult to swallow. And then dysphagia for solids. It presents with benign peptic stricture presents with dysphagia for solids, actually. And scleroderma can also cause esophageal stricture. Then coming, we have esophageal cancer. In esophageal cancer, the dysphagia would present as progressive dysphagia, which is over weeks, and hiccups can be an early sign. Hoarseness can be there, cough if the cancer is in upper third of the esophagus. It is associated with throat pain, and the cancer is squamous cell carcinoma in upper third, and adenocarcinoma is common in distal esophagus. In cancer, the patient also has associated weight loss. Then we have eosinophilic esophagitis. Eosinophilic esophagitis often present as acute bolus obstruction in children and adults, and the patient is complaining of food regularly, food getting stuck in their throat, and patient has also a complaint of gastroesophageal reflux, and dysphagia is also there. So, eosinophilic esophagitis is an allergic disorder, and it is associated with other allergic disorders like asthma. In labs, we have immunoglobulin E is elevated, and eosinophilic infiltrates are common on in esophagus. Symptoms may resolve within. They are actually this disorder is actually common due to some offending food agent, like like cow's milk protein, wheat, soy, seafood, eggs, and peanut. And symptoms resolve within 72 hours of eliminating these type of foods. Then coming towards eclasia. In eclasia, there is widely dilated esophagus. There is widely dilated esophagus, and there is a failure of esophagus to contract. And this is a dysmotility disorder of esophagus. And there is gradual onset of dysphagia for liquids and solids both. It is a differentiating point. Eclasia have a gradual onset of dysphagia for liquids and solids both, and there are intermittent symptoms. When the disease is starting, there is intermittent symptoms fluctuating between dysphagia and regurgitation, and the patient is also complaining of chest discomfort. We have drug induced injury. What is drug induced injury? Actually, the patient is having certain kind of drugs which can injure the esophagus, and the patient is complaining of difficulty in swallowing later on. Especially in such like tetracycline is an antibiotic which can cause painful ulceration in esophagus, due to which the patient is having dysphagia. Delayed passage of some drugs due to some pre-existing disorders in esophagus can cause local ulcerations. These drugs can be iron, aspirin, NSAIDs, bisphosphonates. These drugs make the esophagus prone to ulcerate when there are already pre-existing disorders present in esophagus. Another diagnosis is globus sensation. Globus sensation is a very real sensation complained by patient, as the patient is complaining of a lump in the throat, which is very real sensation. A bolus or a globus kind of sensation is there, and it is usually psychological, and it is not affected by swallowing, and eating and drinking can relieve the pain. What is odynophagia? Odynophagia is pain on swallowing. What can be the cause of odynophagia? Gastroesophageal reflux, esophageal spasm. Gastroesophageal reflux is the most common cause, and we have esophageal spasm, esophageal candidiasis, herpes simplex esophagitis, cytomegalovirus, and esophagitis. These are the infections uh, that can cause odynophagia and dysphagia in the immunocompromised patients, like in the patient of AIDS. Pill ulceration can be a cause of adenopagia when cancer can be the cause, and eclasia. We have some diagnostic guidelines by John Murtagh, which we have to keep in our mind, which can aid in our diagnosis. Like if the patient is complaining of pain and it is localized to neck, we can suspect that the lesion is in oropharynx. And if the pain is from T2 to T6, the pain is usually from esophagus. Dysphagia is associated with pain, and the pain is usually from T2 to T6 location. We can suspect that the pain is from esophagus. In oropharyngeal causes, the classical presentation is that the patient has difficulty in initiating the swallowing, and the food is getting stuck, and there is regurgitation and aspiration of food, and especially liquids. In oropharyngeal causes, like the patients of a stroke. We have another diagnosis, which is pharyngeal pouch. And pharyngeal pouch, we have the regurgitation of undigested food. The classical point for pharyngeal pouch would be that the food that is regurgitated is undigested, and on auscultation there would be gurgling sound positive in pharyngeal pouch. Big 3 points that are common causes of referral to a specialist are eclasia, peptic stricture, and cancer. These are the three big common causes when we have to refer the patient to specialist. Thank you.